neurology, pathology, common brain lesions, and abnormal motor posturing. All right, so for the common brain lesions, I don't want you to memorize all this, okay? Because all the common brain lesions will be touched upon later on within neurology, okay? So this is just kind of a quick overview of what you'll potentially see. But I'm not going to cover every single one of them because I don't think every single one of them is high yield. I'm just going to cover the ones that I think are most important. So I remember getting one question, and I don't think that this is important at all. This is probably the lowest yield thing. But if you have a dominant parietal cortex lesion, okay, and majority of people's dominant lobes are going to be the left parietal lobe, right? The left side of the brain is usually their dominant brain. So it would be the left parietal lobe. And so the one lesion that occurs in the dominant parietal cortex could cause Gertzmann syndrome, okay? And what you need to know here is that they have difficulty problem solving and comprehension. If someone says that they're not able to do like math, then that's Gertzmann, and that's a problem with the dominant parietal cortex. So for most people, it's going to be the left parietal lobe, okay? Once again, lower yield, but I do remember 1 to 2 questions on it. Next, if you have a lesion in the non-dominant parietal cortex, that's going to be for most people the right side of the brain. That's going to be hemispatial neglect syndrome, right? So they have an inability to see what's going on the contralateral side of the world, okay? So since the non-dominant parietal cortex is mainly on the right side of the brain for us, a lot of people have hemi-neglect of the left side, okay? So they're able to see it, but they can't process what's going on the left side, okay? Now, if they tell you, that the dominant lobe or the dominant side of the brain for them is the right side, then you know that a non-dominant parietal cortex will be on the left side. But remember, that's the minimal amount of population that has left side dominance or right side dominance. Majority of us have left side dominance, okay? So a non-dominant parietal cortex would be a lesion on the right lobe of the parietal cortex, okay? And then that would cause the hemispatial neglect syndrome on the left side, right? The contralateral side. That's very important, okay? Next, if you have a basal ganglia brain lesion, it's usually going to be seen in like Parkinson's or Huntington's. They're going to have just a tremor at rest. Once again, they have like abnormal movements because the basal ganglia is going to help with our movements. So you'll have like tremors, chorea, athetosis, which is just like withering of the fingers. Subthalamic nuclei, remember that if you hit the subthalamic nuclei, you're going to get contralateral hemiballism. We discussed this already, but we're going to see it later on as well. Mammillary bodies, usually we're going to see this with Wernicke-Korsakoff syndrome. So patients that have thiamine deficiency, you'll probably see this with alcoholics. They'll come in and they can have Wernicke-Korsakoff syndrome, and they're going to ask what part of the brain most likely is the lesion located at. And it's going to be bilateral lesions of the mammillary bodies, and that's going to be Wernicke-Korsakoff syndrome. The amygdala has a lower yield pathology associated with it. It's called Kluver-Bucy syndrome. Kluver-Bucy syndrome is honestly just disinhibition. So they're going to be hypersexual. They're going to be hungry all the time, hyperphagic. Just like they lose all sense of what it means to function in society, okay? The amygdala is knocked out, and it's usually seen in HSV1 encephalitis. Once again, lower yield. Hippocampus is what's affected in Alzheimer's disease. Remember, you will always remember a hippo on campus, so it's going to be dealing with memory. So hippocampus is for memory, and that's going to deal with antegrade amnesia. For the rest of these, honestly, I wouldn't say there's too many more that are like higher yield. We're still going to cover a majority of everything else later on, but just the last two, the cerebellar hemisphere versus the cerebellar vermis. Remember that the cerebellar hemispheres, that's going to cause your intention tremor, limb ataxia, and loss of balance. So it's going to be usually like problems with the extremities. And then the cerebellar vermis, it's going to be like actual truncal ataxia. It's going to be problems with the central part of your body. And that's going to cause a wide-based gait that you normally see. It can lead to nystagmus, and alcohol overuse can lead to cerebellar vermis damage, okay? And once again, any type of cerebellar issue is going to be ipsilateral. So moving on from the common brain lesions, we have the abnormal motor posturing. So once again, relatively lower yield, but it's worth mentioning that whenever you see someone that has some type of posturing going on after like severe brain injury or damage, you can tell where that brain injury or damage occurred based off that posturing. And the two posturing is decorticate or decerebrate, all right? So decorticate is the flexor posturing, and so that means that your hands are flexed upwards near your heart, okay? And so that tells me that the site of the lesion is above the red nucleus, okay? Meaning that it's usually in the cerebral cortex. So if you ever see someone in the decorticate posturing position after brain damage or brain injury, you know that it's usually the lesion could potentially be, or the damage could potentially be in the cerebral cortex because it's above the red nucleus. Okay? Now, for the decerebrate posturing is the extensor. So all of the extremities are extended out, specifically the hands, right? Because that's the only difference. And that means that the lesion is going to be at the brainstem, okay? Between the red and the vestibular nuclei. Once again, you don't have to know those nuclei, just know that it's in the brainstem. So decorticate posturing, it's usually in the cerebral cortex, so above, and this decerebrate posturing is going to be below, so it's going to be in the brainstem, okay? So that's all for this. Remember, for the common brain lesions, it was just a quick run through, and we're going to talk about each individual one that's high yield later on.